welcome to the Health Go Live webinar series. Today's episode is brought to you by our friends at ClearStep. We would like to remind you that the Q&A feature is available, so feel free to send in your questions for our speakers throughout the discussion. And with that, I will turn it over to our moderator who joins us from ClearStep, Adil Malik.
Great, delighted to be here. And I think all other panelists can come off mute and turn on their video. Great. Well, thanks everyone for joining us today. This is a conversation I'm really excited about. For years, we've been talking about the hopeful imminent shift to value-based healthcare and how new payment, contract, care delivery models will transform US healthcare to reward providers for keeping people healthy rather than just treating illnesses. And the current state of healthcare right now, with rising costs, with revenue loss on the provider side, labor shortages and churn, all these things have highlighted the need to become less dependent on transactional services. So over the next hour, we're going to be diving into where we are on this shift to value-based healthcare, what will be required to reach the destination we're hoping for, and we'll try to dig into whether or not we really are at an inflection point right now, or whether the road ahead is still a long one. I don't think we could have pulled together a better group for this discussion. I'm joined by leading experts on the payer, provider, population health management sides of the conversation. So we have all the voices I think we really need to have a really fruitful conversation here. My goal will be to really push us past the surface level of this topic, really dive into the meat of it so that each one of us can take away a lot of value here. And by the way, you can submit questions in the chat like was mentioned. One of my colleagues on the ClearStep side will help me out with maybe responding to those and maybe curating some of those for us to hopefully have some time for at the end. If we don't have time, what I would ask for is if you could put maybe your email or something with the question that you post, and we can try to aggregate questions we didn't get to and maybe forward them along to the relevant panelists. But without further ado, let's do some introductions. So Ken, why don't we go to you first from MedDecision?
Adil, thanks for having me. Ken Young, President and CEO of MedDecision. I joined on as CEO in April of 2021. Excited to be here and honored to be on this panel with the rest of the team.
Awesome. Alicia?
Yeah, Adil, thank you. So Alicia Stokes, Vice President of Strategy, Planning, and Performance for Government Markets here at Blue Cross North Carolina. I've been here for about 9 years now, and in this position, I have direct accountability over our long-term strategy for our government business, which is Medicare, Medicaid, and our federal employee program, and really happy to be part of the conversation today.
Great, glad to have you. And Randy?
Randy Gaborio, thanks, Adil, and to my co-panelists. I am the Chief Digital and Information Officer for Christiana Care Health System.
Awesome. Well, let's just jump right into the conversation. There's we saw a recent Fierce Healthcare survey and report, not too recent, from November 2021, but it shared kind of a summary of how top health system executives were reporting a really significantly increased intention towards moving towards risk-based payment strategies. I think 60% said that they were seeking value-based contracting arrangements for Medicare in 2022, and we're more than halfway through. Over half said that they're hoping to develop commercial employer-sponsored arrangements. So it seems like, from an industry perspective, that we are at an inflection point. There's a lot of conversation and data that maybe supports that. But let's use that context to maybe first go to Randy. Randy, where is Christiana on the value-based care journey? Do the stats I just mentioned reflect how your organization's prioritizing the shift, and if not, how are you thinking about your value-based strategy?
So those stats actually, in one, for half of my day, those stats feel adequate, and for another half of my day, they feel light. We are absolutely focused on the construction of value arrangements, so we can sort of change the set of tools that we use to basically engage and basically drive health for people. And so, I mean, part of what that means then, this challenge that we face in, extracting yourself or building this new sort of model whilst maintaining the old, the core challenge is you got to have a tool set, you have to have a skill set, and you have to have a mindset to do that work. And we actually sort of start with the opposite, which is driving the change in mindset. So we are very much focused on this as a clear, whether you want to call it a North Star, a core purpose, our priority, the purpose for our being, absolutely driving that. So I guess going back to that stat, the stat actually feels a little bit light. This, fee for service is basically, it's an obsolete method in terms of caring for people. It drives very transactional based care, and patients don't like the resulting sort of model in terms of the experience that they get. So I would argue that those stats are, probably actually higher when you get behind sort of, the walls of an organization that they're trying to figure it out.
So how do you think about goals and objectives? Like, are there key KPIs, measures? How do you know that you're successfully tracking in the right direction? Is it revenue mix, a certain percentage increase in payment or revenue generated from risk-based models?
Well, there's that in terms of transitioning sort of your organization from business model old to business model new. And then the actual sort of within the operations of executing that value-based work, that's really about the measurement of the cost of this population in a fee-for-service world and the cost of managing that population at some point downstream while they've been in a value-based arrangement, and the associated outcomes you're getting for the investment. So thinking about the unit cost that it is for us to produce a unit of healthcare and whatever that is to be consumed, and the outcome that we're getting based on that. So it's sort of a stereo methodology in terms of business transformation and then actually navigating the outcomes.
Makes sense. Are you able to share anything on where you guys are? How are you performing on that? Like anything that's quantifiable? Do you think you're in the right direction, or you're in a good place relative to your objectives?
I think no matter what, when you always look back after you've executed, you always see sort of the obstacles that were in your way that look difficult when you're facing them, and that look, when you look backwards, you're like, okay, we overcame that. So let me give you a great proxy measure, and we'll probably talk more about this in the future. But we have actually partnered and formed a venture with a large Blues plan to effectively sort of kind of attack. And what the realization is, each party trying to go at it on its own and sort of while still living in the same waters of value of fee for service, you really need to partner up and figure out how you actually build a model together, sitting on the same side of the table rather than an annualized transactional based negotiation, which is basically how our entire industry ecosystem has basically operated. So formalizing that relationship, I believe, has sped up our ability to do that, because we're co-creating and we have a co-shared destination. So I'd say we're moving. We've got demonstrated projects. We've got sort of demonstrated capabilities that we've constructed. We've got patients that we're working on. But I will say, every day we wake up and we're like Rocky Balboa. We got to run faster. We got to run harder.
Yeah. Great. No, that's really useful insight. Kind of transitioning to the payer side, Alicia, how is BCBS in North Carolina strategizing this transition to maybe shift premium risk to providers, or even just advance quality payment incentives and initiatives? What are the priorities near and long term?
Yeah. So I would say, again, I've been at the company for about 9 years now. Whenever I first started, we were very early into our kind of move to value strategy. And at that point, it was, get as many doctors signed up for ACOs as you can. And there was not a lot of attention put on shared understanding of what the core capabilities were to be successful in value-based care. It was very much of a transactional relationship. I would say over the past really 3 to 4 years, what we've been able to do is, number one, understand where our providers are and how to meet them where they are, and then also understand some of the specific differences between our large hospital health system partners versus our independent primary care providers. About 40% of the primary care in North Carolina is delivered through independent primary care. And so we really felt like that in order to make the value-based care glide path with providers successful, that we really needed to develop specific programs for our hospitals, health systems that were a little bit different from our independent providers. So as of now, we have, I believe, 9 of the largest health systems in North Carolina, and hundreds of independent primary care physicians are collaborating with us in our shift to value-based care. Blue Premier is our hospital health system value-based care program, and Accelerate to Value is our independent primary care value-based care program. And then we've also embarked on some specialty care value programs as well. So at this point, we have, call it probably about 60% of our membership, and that number continues to grow, is attributed to a provider with a value-based care agreement. And we've seen north of over 500,000 members have seen improvements in their care in 2019. That was in 2019. So we feel like that in setting these 2 arrangements, understanding the differences between hospitals, health systems, and independent providers, understanding their capabilities and level of readiness are different, and then working with them to make sure that we are advancing that transition and that risk to them whenever they are ready, then we feel like that we're putting not only ourselves, but our provider partners on a good, sustainable path to continue to move the needle as they demonstrate success and then take on more risk over time.
Those are super impressive stats. Could you shed just quickly a little bit of light on the differences in those strategies with the practices versus the health systems?
Yeah, absolutely. So I would say core to either one of those arrangements is a platform that we've set up called our value platform. And the purpose of the value platform is simply to increase transparency in how we share information with our providers. So one of the things that we see with our larger hospitals with health systems is that their infrastructure, everything from their IT infrastructure, their electronic health records, and just the overall kind of operationalization of their clinical practices are a lot more mature and advanced and just technologically advanced than our independent providers. The other thing that we've seen is when you think about the number of members that it actually takes to take on risk and do so in a way that is obtainable and sustainable, sometimes these small primary care practices do not have enough members. So along with this value platform that we've created, one of the things that's been really critical on our Accelerate to Value program, which is our program with independent providers, is working with organizations that can help those independent providers almost function in an aggregated fashion. And so we have a partnership with a company called Aledade. Some of you may be familiar with Aledade. Actually, the former Secretary of Health and Human Services for North Carolina, Dr. Mandy Cohen, recently went to Aledade to be part of their leadership team. But what Aledade does is they really help to aggregate these independent primary care physicians and to work with them on everything from what sorts of technological capabilities do they need to be successful, what do their operational workflows need to look like, how do they need to appropriately staff and kind of allow that staff to operate at the top of their license, and then ultimately how do they take accountability and attribution in a much more kind of grouped format so that they can be successful. So again, I think there are alignments across such as this value platform and how we share information. But what we're really seeing is that the differences come within the capabilities that hospitals and health systems have in order to take on this risk, and the absence of those capabilities within the independent primary care space, and how companies like Aledade can help us actually bring those capabilities to the independent primary care space so that they can be successful and have some skin in the game as well.
Wow, super interesting, and sounds like a pretty intelligent approach to dealing with that challenge on the practice side. Shifting over to Ken, Ken, you lead one of the largest suppliers of population health management technology and services to plans and health systems. So what are you seeing in the market? Is that survey data right? Is there an uptick that you've seen in market demand for new technologies and services that can cater to value-based care?
It's a great question. So I think what we're seeing, which I think is the right direction, is a shift away from just focusing on data aggregation and data sharing and how you can make that data more effective for the patient. And then how do you outreach to the patient? Because ultimately, at the end of the day, all of these models require a communication path with the patient in some form or fashion. And when you're doing that, it's not just about aggregating data. It's not just about presenting data. It's how you interact with that patient. And moving from just a retrospective model of follow-up to more real-time interactions is where we're seeing a lot of conversations go, and delivering those real-time communication options, whether it be your full omni-channel, moving away from just telephonic to your personalized outreaches via chat, via text, via email, that are personalized based on the preferences of the consumer. Because at the end of the day, all of this outreach that has to happen through all of these tools has to evolve a patient at some point. And the only way to interact with them is to gear toward that personalized approach toward interaction. And that takes a consumer-centric focus. And we're starting to see folks move away from just worrying about aggregating data and presenting data to what do I do with the data and how can I do it sooner in a more personalized fashion. That's what we're starting to see, and really excited to see that move away. Because I'd say for the past 10 years, yes, we've had some successes, but I'd say overall, I would put out there that the value-based care initiatives have not succeeded on an aggregate basis in a way that we would have hoped. And I think it's because we've lost sight of the patient in that, and that how to personalize that communication with them is what I think was lost over the past 10 years, in my opinion. I think we're starting to see that shift.
So you think that shift is actually something that you can specifically, tangibly look at having happened in the last 2 years, 18 months?
I'd say coming out of the pandemic and having everyone have adopted a lot of technology of communication, everyone's realizing that it's not just about the technology, it's how you put the technology together in a unified fashion, tied with those real-time data events with a personalized outreach that matters. It's not just getting on a Zoom call like we are today, right? Everyone rushed in March of 2020 to get onto Zoom, get onto a Teams, get onto any kind of video-based platform. And now it's how do we appropriately interact with the patient in a way that they want to receive? Because at the end of the day, you do need to work within change behaviors or behavior change. And the only way to do that is through that personalized communication.
So how has that shift to maybe become more personalized and maybe consumer first, how's that impacted your business, right? Where historically you've always been doing care management, and still, care management is I think, the primary thrust of MedDecision's business. So how does that shift in thinking, or what the market needs, have an impact on how you're building the business and what critical business requirements are for you?
Yeah, for us, it starts with the data, obviously, right? But it's not just around landing the data; it's driving those real-time interventions on top of the omni-channel communication, so that you can effectively approach the patient in a meaningful way that they
So
want to
you're doing that outreach, or are you helping facilitate that?
We're
on
helping
behalf of-
facilitate, so we're providing all of the components. Obviously, you also don't want to overburden the system, right? I think it's safe to say that the value-based care initiatives and tool sets have really just added a lot of administrative costs. So when doing these types of personalized outreaches, you want to do it in a way that doesn't add more administrative burden. So what we focused on is how can we deliver that personalized outreach tool set in a way to also lessen the administrative burden. The teams that are doing this are already overstretched. It's not like they're all sitting there and they have a lot of excess capacity. They're already overstretched organizations, and they're at capacity. And to deliver personalized outreach and personalized communications delivers more taxing onto the system. So what we focused on is how do we deliver that personalized outreach and offer those real-time events without overburdening the already burdened system, to lessen the automation. So how can we drive full automation with it? You know, we are at the heart of it a workflow platform that drives automation. So we have focused on taking the data in real time all the way through to the personalized outreach and driving through automation so that the care managers, care coordinators do not have to be overburdened and are over alerted, or they're able to drive automation back to the patient so they get the feedback that they need in real time to address their needs and hopefully better the outcomes and lower the cost.
Right. Makes sense, right? You don't want to actually increase the total cost of care delivery because you're just adding all this administrative costs. So automation, personalization can help close care gaps, keep people on care plans, et cetera, towards obviously the goal of lowering the total cost of care. Makes sense. And that actually is a good transition to the next topic that I wanted to get into. You know, the idea of like personalization and being consumer first is also a really key theme that's been at the forefront of healthcare in the last couple of years, you know, driven probably largely by the pandemic. But how, you know, Randy, what do you think being consumer first means for Christiana? And, you know, if it's a priority and it, how does the consumer and maybe digital strategy connect with or interface with the value-based health strategy? Like, these are two key kind of threads that have been going. Are they connected? And if so, how?
They are connected, but I would argue that just the creation of a bunch of apps that you then start throwing at the customer and then or the patient, you got 5 different apps that are layered in. You've just layered in cost. That there isn't necessarily clinical validation on these tools. You know, there's been a lot of race to sort of deploy tech. And I'll sort of back up when we look at sort of the core work that we did and around our platform and how MedDecision can help sort of power some of that work. You know, we created this concept of a dynamic daily risk score that actually uses the insights on the patient to sort of help you figure out from a proactive triage perspective, what's most important with that patient now, and then how do we serve the information up to the right virtualized caregiver to communicate that. But then how do you connect the digital strategy? Because now it isn't really necessarily the surface area, the amount of data that we're now collecting, right? It used to be when we started this, you might collect some really basic data on somebody and you start, you know, crunching the algorithm and make an assessment. Now you're talking about that surface area of ambient sensors, specific sensors that can detect particular exacerbations, you know, COPD, how am I breathing, you know, continuous glucose monitors, all these components that we now can pull that data in to get even more specific, use that as part of the algorithm to then further refine sort of the sweet spot of, instead of now saying, hey, generically, these are the things we're going to do with the diabetic, these are the things we're going to do with the COPD patient. And instead, the sweet spot on those individual patients within those disease conditions begins to stratify based on your individual need. And then with a digital strategy is then how do I return the information back to you that helps you make the decision to change your behavior or whatever it is we need from you? Is that delivered back via simply as a text, an audio phone call? Is it a video chat? Is it an Amazon prompt? You know, what's the right way? So then you have to begin segregating the populations in a way with what are the right tool sets, because the way you engage a 45-year-old female in a high-income zip code versus a 45-year-old female in a low-income zip code, or, you know, you may need different sets of tools to engage those people. So then you can become very specific around your SDOH type measures. So we just see this, the digital strategy and sort of figuring out as around the value-based strategy and that sort of that consumer first, all those things come together to really feel like, and not just feel like, but actually deliver an interaction that is precise and specific to you. So we'll just keep increasing that surface area with tools that are the right fit tools. We also think about that digital you know, having attended some of the conferences over the last several months, one of the things I've sort of seen is that there's this, you know, there used to be this, the last prior few years, kind of the push of the app for everything. And we're sort of seeing in my observations for this return to the platform to be able to sort of build off that platform. But then you've got all the technology vendors, right, coming out, each of them basically as they want to build a launch point from their platforms as well. So all of these are deeply, deeply integrated and to do that. And frankly, if you look at the cost of low form factor sensors, if you will, you know, these transducers, this stuff is almost at zero. It's so you think about the leaps that are being made in terms of being able to diagnostically observe a patient, one, you know, just in the home, and using laser and infrared technology to determine, not by identity necessarily by a camera, but by these other sensor technologies to know, like, hey, the patient is getting up an hour later each morning. The patient is going to the bathroom, you know, twice a night. You know, so you start to get these, as I call it again, the increase in the surface area, these additional data points that allow you to make a whole separate set of intelligent decisions.
So it sounds like the way that these things are connected, if I'm to summarize what you're saying, is, you know, greater data generation, real-time insights that can be personalized and delivered to people themselves, so they actually have visibility into their healthcare information and data, and theoretically can take action on them. That proposition is or can lower the total cost of care for that patient. Do you have data at Christiana that suggests that being able to do that, or that doing that successfully, is actually lowering the total cost of care?
So internally we have data, and on some of these tools, we've done clinical studies and we'll be publishing the results of those activities. But I will say we continue to invest in these things, which means directionally internally, our data is showing us that it's a continued worthwhile investment to move this direction.
Yeah, makes sense. And Alicia, similar questions to you, right? Like, what does being consumer or member first mean for your organization, and how does that interface with a value-based health strategy?
Yeah. So I think kind of if you take a step back and say, hey, like, what is the definition of value? Here at our organization, we kind of see it as three different components. We see value as being return on health times return on affordability times return on experience. I think there was a time in our kind of learning over the value-based care world, which we kind of thought of those things as additive, and where we said, well, you can return on affordability and return on health and the experience be horrible, and that's okay, right? Because you still get value. I think you've seen, you know, the influx of kind of new players within the healthcare field, right? Now you've got Bright Health, you've got Oscar, right? You've got traditional payers moving into these diversified business groups. And so what we've now seen is that those aren't additive, they're multiplicative, right? And now the expectation, particularly with the Amazons and the Googles and the Walmarts of the world jumping into the healthcare space, is that a return on experience is expected. I think when we talk about digital, we like to think about how does digital help support those three that I just named, right? How does digital help us get a return on health, return on affordability, and a return on experience? And then how do we leverage what we know about our consumers to drive improvements in those three areas, and to also just drive efficiency, and how can digital help with that? One of the examples that we've that kind of speaks to that and to how we're incorporating digital within our kind of value-based care world is that a couple things. Number one, we have made some significant investments in what I will call digital capabilities to help providers play in the value-based care world. One was a recent organization that we developed called Allo. And Allo's primary responsibility is to help bring capabilities to the market, largely digital capabilities to the market for independent providers to help them remain independent. Again, you heard me say earlier that around 40% of the primary care physicians in North Carolina are independent. And we think that is part of not only our local presence within North Carolina, but part of our mandate to continuing to deliver value to our customers is helping those independent providers remain independent. So Allo is one of those investments that kind of speaks to capabilities that we're bringing to providers. Largely of those are digital. The second thing in understanding, hey, how can digital help, is we are on I think we are now 44 counties in to a tour that we call the Extra Miles Tour. Being that we are an 89-year-old local North Carolina-based not-for-profit that only operates in North Carolina, we have the privilege of being able to get really, really deep within our local communities and understanding the needs of our population. So members of our senior leadership team are actually visiting all 100 counties over the next year and a half to really, truly understand what are the needs of consumers. And they're not talking solely to large hospital health system executives. They're talking to folks at community colleges. They're talking to our members of our tribal communities, of our LGBTQ communities, our community-based organizations, to find out what are their challenges and how can we help solve for that. One of the big things that we've learned is that we actually have a significant amount of community-based organizations to help solve for some of the drivers of health, like food insecurity, but that there's not enough infrastructure to allow our community-based organizations to communicate. So when we think about kind of that example and the things that we're learning on this Extra Miles Tour and how digital can help solve for that, we're trying to make sure that we can connect any of the digital capabilities that we're bringing to bear with what is that direct impact going to be on one of those three value verticals, right? Whether it be return on health, return on affordability, and return on experience. So that's kind of the external lens of how we're doing that. Internally, I would say, without kind of getting too much into the sausage making, we have formed a way that and a forum for how work gets resourced and how work gets funded. That requires all of our different business areas to not only bring their ideas forth, but to be able to actually articulate what the interdependencies are of that idea with other areas of the organization. So for example, if I want to bring a food benefit into our Medicare Advantage population, and part of being able to implement that food benefit means that I need a digital or technological infrastructure to be able to connect to the areas of North Carolina that can help deliver food. I have to be able to articulate in my business case, what are the digital components that I need in order to make that happen, which then requires me to reach out to my digital counterparts over in our operations and member experience area and actually bring them to the table in helping develop my business case. The only way that that idea is going to get approved through this investment committee is if I can show direct articulation of what the digital capability is that I need, and that I can show jointly that I'm working together with our vice president of digital in understanding how that digital capability is not only going to come alive, but then how it's going to actually help impact that value equation. So those are just kind of some of the examples of how we are incorporating digital into our value-based care strategy. To put it bluntly, like I can't move forward and move the needle in value-based care without driving some efficiencies. Part of driving efficiencies is leveraging digital, but then part of leveraging digital is being able to map that back to the value that it's returning from a healthcare perspective.
Yeah, that makes a lot of sense, and I appreciate the level of detail that you shared. Ken, going back to you, you kind of started this discussion or this thread on the consumer first kind of transformation. So how, and you touched on this a little bit, but I want to go into a bit more detail on how you're kind of managing this transition, right? Population health historically has been very, very manual in the outreach and in the engagements, telephonic nurse outreach to high risk members to try to get in touch and close care gaps, present care plans. So what's specifically, or more specifically, on the roadmap for becoming more consumer first and automated and digital, kind of things that you alluded to earlier?
Yeah, so what we have focused on is definitely it's probably multifaceted. So it starts with data. It's not just payer or generated data. We bring in payer generated data. We're bringing in provider generated data, the ADTs from a real-time perspective. We're bringing in remote patient reported data like remote patient monitoring. We're also bringing in whole person social determinants to create that holistic view of the patient. That is just the data side of it, right? So after you've aggregated the data, it's now what do you do with it? And this is where the personalization starts to come. We personalize with the data around the social determinants, the patient reported data, the ADTs, and the claims, pulling that all together. It's now how do we deliver that personalized automated outreach?
Right.
And it starts with identifying your populations. We're creating personalized care journeys. So you can create a population that is just like Randy said, you interact with someone who's age 45 differently you interact with someone who's age 55. And that goes to our strategy. We are not adding another app to the encumbered app ecosystem. We are API first. And we are also app-less. So it gives you the ability to customize your outreach. So if you have a population that is not oriented toward apps, you can deliver it, but they still have a phone. You can deliver an app-less experience that is still secure text, secure chat, secure scheduling, all with outside of an app. And that could be done with one population because that's what that population needs. But then you have another population that will definitely want to drive through an app. Well, we take our APIs and you embed it into your already existing mobile assets, any pane of glass. So we work nicely within your already mobile ecosystem, not trying to over encumber with yet another app. So take our APIs, embed it into your app, and you create a custom care journey for that population, driven off of that holistic data in real time. And then you get the customized based on the preferences of that patient. Is it a text? Is it a chat? Is it an email? And you do that effective outreach, and that drives all automation. So that's done in real time with automation so that the care manager isn't having to realize that this patient is being discharged from an ER and they need to, follow up with their primary care in 7 days. That is all being done through automation so that there is no manual effort for a care manager or care coordinator now to go in and do. All of that is driven from those custom care journeys, starting with the data, but then finalizing it with that personalized delivery mechanism, and knowing that not one size fits all. It's not one app. It's multi-modality, right? You have to have app lists, you have to have apps, and we want to work nicely within all of our clients' mobile. All of our clients have made significant investments into mobile assets. We're not trying to supplement or replace any of those. We're trying to just augment and enhance those already existing mobile assets and make them smarter. Like Randy said, you have a lot of devices out there where, how can we make everything smarter and more consumer centric so you get that consumer experience that Alicia was talking about? How can we deliver that what every consumer expects in an experience that they're not getting in healthcare today? And that's what we've been focusing on, starting with that data, but driving through those custom personalized care journeys in automation and in real time so that the outreach can be personalized. So it's kind of multifaceted, and that's what we've been focused on to deliver that consumer experience that's been missing.
So that makes a lot of sense, in theory. How close to reality, right, is that end-to-end experience and what you're delivering with your customers today, right? Like, how is this something that's happening right now? Is some of that future state going to happen? And then related to that, right, like, are we seeing the impact of that on total cost of care figures? Are there real objectives being met with that transition?
So the reality is all of this is real and available, but what we are seeing though is every payer or provider is adopting these components at a different pace, and we enable that our customers to meet them in their journey where they are from a digital experience. Going to what Randy said around creating that platform, we have the platform, but we're not making you consume the entire platform out of the gate, right? That's not effective either. So we're taking our clients on this journey. Some are adopting them much faster and a lot further. Others are going a little slower. But knowing that they have the ability to add these on components, they can add in ADTs whenever, they can add in the omni-channel whenever they need to. But knowing that they have the ability to not yet bring in another digital asset, but they can take the platform approach and do it at their pace, of adoption and change.
Makes sense. Makes sense. But promising to hear that this is current state, right? And the limiting factor actually is just how fast can the organizations you're working with actually move to
The
adopt.
big thing again, and I think we haven't touched upon this, it's not just about the tool set, it's also about the economics that surround these contracts. We can deliver the best tool set, and we believe we do, but it has to be supported by the financial constructs of that value-based care arrangement for it to be effective. You can't, we have to change that to be more effective in value-based care arrangements to deliver better outcomes. The financial incentives have to change.
Yeah, so that actually is a perfect bridge to a little bit of something like I'm personally very just interested in an area to dig a little bit deeper before we transition to just a final topic. Kind of going off of what Ken was saying, Randy, are you able to share what is the current rough distribution of revenue that's purely fee for service tied at Christiana versus has some value-based component to it? Are you talking 95-5, 90-10, 70-30? Where are you right now?
So I'm not giving internal numbers that have not been blessed by communications folks. So
sure. Well, so industry, if you can speak to even. Where you think people are?
I think the industry is probably sub 15%. I'd say if you're 15%, you're probably at a healthy clip in the industry that's meaningful enough inside the organization you need to be successful with that. So and let me just start. I think strategically wise, the model that we've been operating under is this sort of low frequency interaction with the patient population in fee for service, but it's high acuity. When we finally get them, they show up and they are sick. And so you look at HEC scoring and the like, and you can see the population of people that are finally showing up because of pain or other issues is significant. That shift, as you know, is for us to use these tools, the technologies, and the value with a business model to drive high frequency, low acuity. So much more granular engagement. And just part of this thesis for us is a strong sort of belief in the proving out that we can make the digital experience actually better than human to human, because human beings have variation in their days. There's good days and bad days. And you get that whenever you call a customer service sort of center around that. So we have internal goals and targets in terms of the amount of two things. The number of first-time touches that we have with somebody that's purely digital, the number of follow-up or ongoing relationship percentage that is digital, and then 3, the amount of total lives served under fee for service versus value-based contracts. And then we break those up, obviously, then stratified across the different payers in our markets. And so we have targets, and then we engage with the payer community to then figure out how can we work together to tackle this particular shared population to basically drive outcomes and reduce the cost. Now, we also have a goal. Our objective is on those populations is to save 15% on that population over what is determined to be the sort of the appropriate measurement period based on the difficulty that patient faces, the disease condition, where they are, and the behavioral things, and then the tools that we deploy wrap around with actual live service and human beings to do that. So that's sort of a calculated path for how to get it, and then we can sort of estimate what the sort of the return on those lives will be over what they would have been in a fee-for-service calculations, just doing LTV calculation, acquisition cost and the like. Yeah.
So that's super interesting. And the one quick follow-up question, I know we're running out of time, but this is a big question, but I'm hoping for that you have maybe a high-level response to it, or a quick response to it. But it feels like to me that when you look at the provider-patient relationship, providers aren't really looking at what contract, what insurance plan someone's on when they're delivering care, right? And if it's 85% of the time fee for service and 15% value based, then all their micro interact, it's just embedded in the way that they think and have been practicing medicine to do the test, do the next thing, not really follow up, not actually be super mindful of the long-term health, but just do what's needed in the exact moment. And it feels like you can only get the change that we're looking for with value-based care if you're at like 90-10 value-based and fee for service, completely flipped in where revenue is coming from. Then it feels like at the micro level of the actual provider patient interaction, you'll start seeing tremendous changes in the way people are working with their patient populations. Can you speak to that challenge, or if you even agree with what I said?
Well, I do agree in the dimension that that providers, at the ambulatory level, whose daily life is filled with the high volume, serialized sort of treatment of their patient, their panel. I think that it's very difficult for them to sort of weave or bob in and out of sort of like, oh, this patient's this patient's that. I think that they work towards delivering the highest quality of care and subscribe that across all patients. And if there is a threshold of sort of measurement or tools or things you have to do, I believe that those sort of tools, if they're the highest level of care ascribed to population X, that they will migrate those things across their population. I don't know that 90-10 is that number, but what is clear is you as systems delivering care, we have to be building the next generation model while still living in the existing model, because you still got to deliver care. And I'll tell you, Alicia and team, is a forward-thinking Blues, but not every payer on earth has sort of the capability to manage and build out the technology platform to support value-based models. So that takes some work to do with as well. And then folks like MedDecision are able to sort of step in and sort of help fill that transformation gap, and then become a durable platform to do that type of work.
Yeah, that makes a lot of sense. And relatedly, Alicia, and I'll ask this question, and then I think I'll do a round robin on a final question and parting thoughts with folks. We may not have time for questions that came in, but I was told that we have everyone's email addresses against the questions that were submitted. So I'll try to follow up, or we'll send some sort of follow up, maybe key themes to further address questions. But Alicia, how willing, when I think about the big picture of this, like how willing are payers to even really shift premium risk to providers? Because it feels like the biggest margins can be made there, right? In managing those populations well. Obviously, it's more on the Medicare, Medicaid side for payers, but how, it seems like that could potentially come at a loss to payers to actually reform the economic models here. How do you think about, one, do you even agree that may be the case? And two, how do you think about that challenge?
Yeah, so I think that answer is different depending on who the payer is. If you were to ask my for-profit competitors, they would tell you that bringing in those high margins is core and central to what they have to do, because they have to return shareholder value. I don't have shareholders, right? My shareholders in and of themselves are the customers and communities that I serve every single day. So, historically, pre-ACA, in order to maintain your high margins, all you did was you did underwriting, right? Any sort of increased medical or administrative risk that you took on, you passed it to your customers in the form of an increased premium. I think here at Blue Cross North Carolina, we understand that part of what we have to do is to maintain price competitiveness, but to also make sure that our members have the benefits that they need in order to live their best lives. So whenever I think about kind of that investment in value-based care and shifting more of that risk over to providers, and how that may impact margins, to me, it's not about margin. It's about how can I do what we do best as payers. How can we help providers do what they do best as the kind of care delivery infrastructure? And then how do those two things work together? And how do we kind of transition and stop doing some things on the payer side as we look to transition more of that risk to the provider side? Something that I said, Ideal, in our initial conversation a couple days ago is I talked about this kind of convergence in payers being the financial institution, and providers really being the care delivery institution. and how oftentimes when we think about both of those entities together, we can get really, really bogged down in the math, right? And making sure that everybody has an opportunity to get margin. And we kind of get away from the central point, which is what outcomes are we trying to drive, right? One of the things that we've really focused on here at Blue Cross North Carolina is really getting very clear internally, as well as with our provider partners, on what are the outcomes that we're trying to drive, and then what are the capabilities needed to actually drive those outcomes. And then over time, how might those capabilities shift from payer to provider in order for us to make sure that we are providing the best outcomes. So one of the things that we've done here is we've actually developed what we call a provider readiness scorecard, which allows us to go through probably about 8 to 10 administrative functions, plan functions, and say, how does a provider score within these functions? And then based upon how they score, what is their level of readiness to take on that delegation? And then what that gives Blue Cross North Carolina the opportunity to do is to say, how do we stop doing some of those things, and how do we create more delegation oversight versus actually delivering those services and those capabilities ourselves? And then again, because of our purpose-filled, mission-driven mandate, as long as we can make sure that in delegating those things that we're creating and providing value to that original equation, right? Return on health, return on affordability, return on experience, then the delegation is the right thing to do, regardless of what it does to our margins.
That makes a lot of sense. And a lot of challenges in what you described, depending on for-profit, nonprofit. Can kind of final thoughts here on I think two main questions. One, what do you look for in your payer provider partners to deliver the most successful solution here and actually move the needle? And then two, and these will be the same questions for both of you as well, just with other parties. And then two, going back to the original question, are we at an inflection point here in what we'll see for value-based care? Or is there a lot, is the road a lot longer than that?
Thanks. So we're laser focused in not focusing just solely on delivering care management reports, deliver on a contract with a large employer, but really focused on the outcomes that the process that using our technology will yield. So aligning on those KPIs and understanding how we can help an organization move. And it's not just during an implementation. This is a constant education. We work with our clients to know, and how can we help, because their business changes, their models change, right? Their mix of population changes. So we have to constantly be, fine tuning the solution to ensure that we're achieving those outcomes and not just delivering a tool set. So that's what we look for and partner with our payer and provider clients. I do think we're at an inflection point, because I think we've exhausted the patient-centered medical home concepts. We've exhausted the value-based care. We've exhausted the Medicare Advantage. I think we've exhausted everything, and we've yielded very little results. I think in certain pockets we've gotten great results. You've heard from Alicia today, but overall, as a nation, we have not moved the needle in lowering administrative costs and improving quality. And I do think we're at that inflection point. I think we're at that point post the pandemic, to start to deliver on the promises that were set decades ago, and now focusing on that. So I do think we're at that inflection point. And I think more folks are open to looking at those financial incentives, because it starts there. If those financial incentives don't change, it doesn't really matter what tool sets you put in place. They have to be aligned, and the tool sets have to enable that.
Yeah, makes sense. Randy, same question to you. What do you look for in your payer and maybe vendor partners to ensure the success of these value-based programs? And are we at an inflection point or not?
Well, first, shared values begins with that. So you have sort of the alignment that between the two companies, and realizing that a lot of folks that begin the relationship are not the ones that are actually executing the work. So I'll start with having that mindset. Two, being willing to go in and basically share in risk. And that doesn't need to be 50-50, but you've got to have some degree of willingness to sort of share in what your platform takes. So if we're taking on risk, that needs to kind of move down into the value chain with taking risk. And I guess three is, people who are energized and have that aspiration to basically, at the same time, we're digitizing medicine while we're digitizing healthcare, and sort of, people that are energized to do that sort of work. And then I guess last, it's just this understanding, this rebuild of the bill of materials of healthcare today for, from a patient going from the first symptom of knee pain all the way to restoration of function or your chronic disease and managing that. The components, the bill of materials that it takes to sort of get the patient to their determined shared outcome, jointly decision made with their caregivers, getting to that same shared place and being able to do that, and sort of, if you're energized by that, that makes sense. What we don't want is people that are looking for a transaction. We want people that are willing to sort of, drive down the road with us, because getting the results does take time.
Makes sense. And are we at an inflection?
I think we're always at an inflection. Let me say, we're right. It will never, things will never be this slow as they are today. So when we look back at it, so I'd say there's an inflection point, probably because I think there is, the pandemic put a lot of pressure on, and it demonstrated certain things around our ability to scale tele and the like. So I think that there'll be some residual work there that's putting pressure on the system to move faster than it's had a pressure before.
Yeah, makes sense. Alicia, we'll close with you. What do you look for in your health system partners here to achieve the goals of value-based care and vendor partners as well? And then that same question on are we at an inflection?
Yeah, I think similar to what Randy and Ken have said, alignment of values is really important. One of the things that we have started doing here, not only with our provider partners, but also with vendors that we're bringing in to help us, and we've actually stopped referring to them as vendors and referring to them as partners as well, is one of the things that we do in our initial meetings with them is we ask what their why is, which is like, why are we sitting here, right? What are we trying to do? And I will tell you, Ideal, I was in a meeting this morning with a partner where we asked that question, and we went around the room. There were probably 15 of us in the room, and for the first hour and a half, we talked about what our why was. And you heard a lot of personal stories. You heard from physicians who said, like, I went to med school to care for patients, and I am frustrated that I spend 90% of my time staring at a tablet or a keyboard. One physician was almost in tears, where he said, I went to school to not only care for my patients, to care for my family, but 70% of my kids' soccer games I miss. And I feel like I'm failing as a father, and I feel like I'm failing as a clinician. So I think the alignment of the why is really important, because if you're truly investing in a partnership, things are going to get hard as we go down this glide path together. And it's that alignment of our why that will bring us back to the center and help make sure that we march through things together. So that's one of them. I think the second is alignment on capabilities needed to be successful. I talked a little bit about some of the work that we're doing, not only to understand where provider capabilities are, but to also help them advance their capabilities. And then the third thing is just that willingness to serve, right? We at Blue Cross North Carolina really have a service mindset, and we want to make sure that the ability to serve our customers and communities remains front and center for our provider partners, as well as for other partners that we may bring in to help improve and increase capabilities. So those are kind of the three things we look for. With respect to, are we at an inflection point? I would say yes. Our former chief medical officer used to say that how we pay for care matters because it signals what we value. And today, one would largely say that if we are in a fee-for-service mindset and environment, then we are signaling that we value more tests, more visits, more surgeries without regard to outcome. And I don't think there's a single clinician that will look you in the face and say that that's what they value. And so if we truly want to change the signal that we're sending to consumers, then we have to change the financial model that wraps around those consumers so that we can change the mindset on what we value. And then the last thing I'll say that really helps emphasize that we're at an inflection point is look at Amazon, right? So they've now bought, they got PillPack, they bought Iora, they just announced last week they bought another provider organization. And when you kind of take a step back and take a look at, and I think CB Insights did a good kind of download on this last week, when you take a look at all of the capabilities that Amazon has garnered over the past decade and how they're ready to jump into the care delivery space, I think it's incumbent upon us, the folks who have been in this game for a while and the folks who really have a health service focused mindset, to figure this out, or big behemoths like Amazon are going to come in and, quite frankly, they're just going to sink us. So yes, we're at an inflection point, and it's up to the folks that are on the line and on the phone today to help do something about that.
Yeah, for sure. And, I'll say at ClearStep, we spend a lot of time as a technology company really thinking about and trying to deliver an experience that enables people, patients, consumers, members to be able to have control over their healthcare information, clinical intelligence, and know what to do for care at all times and at any point in their journey, and create the kind of self-service and digital and automation. And we're excited to be able to work with groups like MedDecision on the pop health side, and health systems and payers, and furthering that mission. With that, I want to thank the panelists here for a really awesome, engaging, and insightful conversation. Truly, I did learn a lot through this hour, and I hope that goes the same for everyone who listened in, and for the panelists as well. So thank you everyone for the time, and we appreciate you listening in.
Thank you to Adil and all of our speakers. Please visit our website at hlth.com to catch up on all Health Go Live webinars. And join us in Las Vegas, November 13th through 16th for Health 2022.